the WHO Africa media briefing, which is taking place in collaboration with APA Group. I'm Tshepiso Makwetla, your moderator. Thank you so much for joining. So today we'll be looking at how a new testing tool can increase testing in Africa. But before we do that, please, a few house rules. Choose your language selection on the globe icon at the bottom of the Zoom app. You choose either English or French, as the broadcast is being simulcast. Francois, if you could just assist in, translating that in French.
Bonjour et merci à tous d'être connectés pour ce point presse. Vous pouvez choisir la langue dans laquelle vous voulez entendre la conférence en utilisant l'outil d'interprétation de Zoom qui est le globe dans la barre d'outils, et vous pouvez choisir le langage.
And colleagues, we'd also appreciate if you could please use the Q&A function to ask your question. We do have colleagues who will be asking questions live as well. So if you are able to, please indicate so. Let me please introduce to you our esteemed panel. Joining us from Congo, Brazzaville, Dr. Matshidiso Moetu, who is the WHO Regional Director for Africa. She'll also be joined by Dr. Nsenga Goy, as well as Dr. Sheikh Omar Koulibaly. From Conakry, Guinea is Professor Abdoulaye Toure, who's the Director General of the National Institute of Public Health. Welcome to you as well. And a warm welcome as well to Dr. Susan Ndide Nabada, who's Head of National Health Laboratory Services and Central Public Health Laboratory. She joins us from Kampala, Uganda. And please, if I could remind you, colleagues, to please put yourself on mute if you are not speaking. A reminder to the panelists as well that the opening remarks are just about 3 minutes long, so please try and keep to the time. Let us now hand over to Dr. Moetu, who will tell us about the new antigen-based rapid diagnostic tests. It's over to you, Dr. Moetu.
Thank you very much, Tshepiso, and thank you also to our APO group colleagues, as always. Good morning, good afternoon, bonjour, bon dia to everyone, and thank you all for joining us for this press conference on how the widespread use of high-quality rapid testing in Africa can revolutionize the continent's response to COVID-19. I'm very pleased to be joined in this conversation by Professor Abdoulaye Toure, the Director General of the National Institute of Public Health in Guinea. Bienvenue, Monsieur le Professeur. And Dr. Susan Ndide Nabada, who is the head of the National Health Laboratory in Uganda. Welcome, Dr. Susan. African countries are gearing up to introduce antigen-based rapid diagnostic tests on a large scale. And this will be a game changer, we think, in the fight against COVID-19. These high-quality rapid tests will help meet the huge unmet need for testing in Africa. While there are testing challenges in many parts of the world, we've seen that African countries have faced a significant gap throughout the pandemic. For example, Senegal has significantly boosted its testing capacity, but it still has testing 14 times less than the Netherlands. Nigeria is testing 11 times less than Brazil. In Africa, countries are mostly conducting PCR tests, which require laboratories, even if they are mobile labs, as well as reagents and experts, leading to a concentration of testing capacity, mainly in the capitals or in large cities. The new rapid tests are easy to use, cheaper than the polymerase chain reaction or the PCR tests, and provide the results in under 30 minutes, enabling countries to decentralize testing and speed up the turnaround time for results to quickly reach, identify, test, and isolate contacts of positive cases. Currently, most African countries focus the use of their stocks that they have of testing kits on testing travelers, patients, or contacts. And we estimate that a significant number of cases are still being missed. With rapid testing, authorities can stay a step of COVID-19 ahead by scaling up active case finding in challenging environments like crowded urban neighborhoods and communities out in the countryside. Rapid community surveys can be done in areas where the virus might be circulating to confirm and quickly intensify surveillance and other public health measures. Globally, 120 million of these tests are being made available to low and middle income countries through the WHO ACT Accelerator Coalition. In Africa, the Global Fund, UNITAID, FIND, and the Africa CDC have linked up to distribute the tests, and we greatly appreciate the partnership of these agencies. WHO is working hand in hand with countries by sending out key policy and operational guidance documents, developing a training package, and deploying experts in the field to support the rollout of these tests. Turning then to the COVID-19 situation, there are now more than 1.67 million cases on the African continent and 40,400 people who've sadly lost their lives. In the WHO African region, which is mainly sub-Saharan Africa as well as Algeria, we have had 1.27 million cases and 28,600 people have died. The region has experienced a downward trend from a daily average of more than 15,000 cases in July to less than 4,000 in the past month. But in the past couple of weeks, this decline has slowed down to a plateau. As countries ease restrictions on movement, some increases in cases are expected, but preventing an exponential rise is absolutely critical. We can do this using public health capacities to find, test, isolate, and care for cases, and to trace and isolate their contacts. We all have a role to play in wearing masks, keeping a distance, and frequently washing our hands to protect ourselves and those around us from infection. Together, we can keep cases low and protect our communities. Finally, while much of our energy is focused on COVID-19, this Saturday, we will commemorate World Polio Day. This year, Africa was certified free of wild polio virus, and I once again congratulate and thank the governments, the communities, and partners for your tireless commitment towards achieving this goal. The fight is not over, and vaccination campaigns remain critical to end all forms of polio. Despite the COVID-19 pandemic, 35 million children have been vaccinated across 13 African countries since campaigns resumed in July. This is really remarkable, and it shows that health service delivery in other areas can be sustained by working together with determination, innovation, and solidarity, despite the context of this pandemic. I look forward to our discussion today, and I thank you once again for having joined us. Thank you. Tsepiso, over to you.
Thank you very much, Dr. Mweti. And we now hand over to Professor Abdoulaye Toure, who, as we mentioned, will talk also about how rapid diagnostic tests have boosted Guinea's testing capacity. If you could please just expand a little bit more on this, what has been the material difference, Professor Toure? Professor Toure?
Merci aux organisateurs. Merci à Dr. Moïti pour cette initiative. D'abord, je suis un peu désolé, peut-être que la caméra, l'image ne sera pas très bonne parce que je ne suis pas au bureau ce matin, je suis un peu loin, donc j'ai essayé de trouver un endroit où la connexion peut être meilleure pour me joindre à cette conférence. Expérience de la Guinée, je voudrais rappeler d'abord que nous avons commencé à réfléchir à l'utilisation de ces tests de diagnostic rapide depuis très longtemps, depuis le mois de mai-juin 2020, et parce que nous étions confrontés très rapidement à certaines difficultés. Nous étions dans un contexte d'urgence avec des restrictions de déplacement. Il n'y avait pas suffisamment, nous n'avons pas de laboratoire de biologie moléculaire qui était fonctionnel sur toute l'étendue du territoire pour faire le diagnostic du COVID. Et donc, les 7 laboratoires qui assuraient le diagnostic COVID étaient concentrés à Conakry, avec seulement 2 qui étaient à l'intérieur, mais les 2 qui étaient à l'intérieur étaient encore très proches de la capitale parce qu'ils étaient environ 50 et 137 km de la capitale. Autrement dit, les capacités nationales en termes de diagnostic du COVID étaient concentrées plus ou moins dans la même zone. Et il y avait également le fait que les autorités nationales avaient conditionné le déplacement de la capitale vers l'intérieur du pays, parce que c'est Conakry qui était le grand foyer de la COVID, que le déplacement vers l'intérieur du pays était conditionné à un test négatif. Donc, ce qui augmentait ainsi des demandes en test, et les laboratoires de biologie moléculaire étaient complètement submergés. Donc, c'est en ce moment que nous avons des tests sur des tests de diagnostic rapide. Et les tests qui nous ont été proposés étaient nombreux, comme vous le savez. Il y a des TDR IgG, IgM, donc sérologie, et il y a hygiénique. Et nous avons fait le choix de ne pas évaluer en ce moment-là des TDR anticorps, IgG, IgM, parce que ce n'était pas notre priorité. Notre priorité était d'évaluer donc des TDR antigènes. Et pour cette évaluation, un certain nombre de tests de diagnostic rapide ont été proposés par les firmes, 4 au total, mais nous n'avons pas retenu tous les 4. Et pour leur évaluation, nous avons, à l'Institut national de santé publique, mis en place un protocole pour leur évaluation, donc qui était adapté au fur et à mesure qu'on recevait de nouveaux tests de diagnostic rapide. Et les critères d'évaluation étaient, entre autres, le fait que tous les éléments qui doivent rentrer dans la réalisation du test de diagnostic rapide étaient au complet. Parce que nous avons constaté que certains livraient des kits qui n'étaient pas tout à fait complets. Et par exemple, pour les TDR anticorps, qui n'avaient pas de lancet, donc c'est difficile de piquer. Et également, nous avons vu des TDR antigènes également qui nécessitaient la lecture avec la lumière ultraviolette, ce qui ne pouvait pas être facile à utiliser dans des zones reculées de l'intérieur du pays. Et évidemment, dans ces critères d'évaluation également, rentrait en compte la sensibilité, la spécificité, la valeur prédictive positive, valeur prédictive négative. Donc ainsi, nous avons fait les évaluations. Nous avons retenu au mois de juin-juillet un test de diagnostic rapide qui avait une sensibilité très élevée, de plus de 80%, une spécificité depuis le mois de juillet d'augmenter considérablement les sites de prélèvement, de réalisation des tests, de faciliter le déplacement des populations vers l'intérieur du pays, et également d'alléger un peu le travail pour les laboratoires de biologie moléculaire. Et donc, nous avons ainsi rendu disponibles ces tests à l'intérieur du pays partout, et également dans des zones de concentration de personnes, dont les sites miniers, parce que la Guinée, c'est un pays à exploitation minière très forte, et des barrages hydroélectriques où nous pouvons rencontrer plus de 3 000, 4 000 personnes à la fois, et également dans les prisons. Donc, ce qui a permis aujourd'hui d'augmenter beaucoup la capacité nationale, de réaliser au moins donc, vous avez dû le constater à travers les chiffres que, certes, en Guinée, nous avons beaucoup de cas, mais la létalité est très faible parce que le diagnostic est probablement aussi un peu précoce. Donc, je voudrais dire donc que l'utilisation de ces tests de diagnostic rapide a été une opportunité pour la Guinée, et nous pensons que leur introduction systématique dans nos différentes stratégies pourront faciliter la surveillance de la maladie, et également de mieux gérer l'épidémie. Donc voilà en quelques mots ce que je voulais dire. Je vais laisser plus de temps à ceux qui vont poser des questions pour revenir.
Indeed. Thank you very much, Professor Ture. And there are journalists who already have indicated that they have questions to ask. And just a reminder to my colleagues, please use the Q&A section to indicate that you do have a question and to whom you'd like to pose it. And please also tell us which news agency or entity you're representing. Thank you very much for sharing the Guinea-Conakry experience. Professor Ture, let's now move to Dr. Susan Ndide Nabada. You can tell us about Uganda and your hopes for the rapid diagnostic tests and how they'll improve your situation. It's over to you, Dr. Nabada.
Thank you very much. Good afternoon, good morning, everyone. In Uganda, since the pandemic started, we've been using and we are still using the PCR test because that is what was recommended, and we went ahead to map out our PCR capacity across the country in line to increase the access to testing. And we actually mapped out a number of labs that could take us to 10,000 tests per day. But as we all know that the issue with PCR is accessibility of the reagents globally, the costs of the reagents, the need of the infrastructure, and the need of a very highly competent technical staff to do the testing. So when we got, and this needs to transport samples from the site where the samples are collected to these testing labs, including transportation costs. But as we stand now, despite of the capacity that we have, in the labs, because of the reagents, a few labs are testing, and they are mainly in the capital cities, like in Kampala. Our reference labs like Uganda Virus Research Institute, the Central Public Health Laboratories, and we set up a few mobile labs for purposes of points of entry. But when we had the guidance by WHO of use of antigen RDTs mainly, we were excited because we all know that the antigen RDTs are, for those that have high quality, are reliable, they are less expensive, they can give faster diagnosis and can be easily used by people next to the health facilities. So we went ahead to validate some of the antigen RDTs that had been brought in the market for validation. And we actually have like one so far that meets the WHO criteria of the specificity of greater than 97% and the sensitivity of 80%. And that is the standard Q. But this sensitivity increases up around 91% if we have actually symptomatic cases with very high viral load. So we think that the use of the antigen RDTs will be a very big game changer in our testing capacity because one, we shall expand access to testing beyond the few labs that we have where we have to transport samples from wherever they are across the country to these reference labs, to having tests done in health facilities, in communities, near patients. So we think we're going to increase access to testing because we also have the small labs use the RDTs in case we train the people. We shall also reduce the turnaround time of results because currently samples are transported to the testing labs, including transportation, time of transportation, the actual testing that takes between 1 hour to 4 hours, and return of results. So we shall reduce the turnaround time of patients getting results, of health workers getting results, and they immediately act on the patients, and this will help us isolate the patients immediately, break the transmission early, reduce exposure to the health workers because they'll have timely and quick diagnosis of these patients. So we shall reduce the turnaround time from what we've been having. Our average turnaround time is between 48 to 72 hours, but we all know RDTs can give you results between 10 to 30 minutes, depending on the antigen RDT. It's also easy to perform. It is simple. It doesn't need highly sophisticated infrastructure and very highly technical competent people. So we can scale it up even to the lowest health facilities and in communities, hence increasing access and increasing the people we can test, because it's very hard to massively test using the PCR reagents because they are very expensive. So we think this will take us a milestone ahead in increasing access to testing. But as we do this, we are all guided by WHO, especially that if we are introducing RDTs, rapid diagnostic tests, we need to have in-country validations. We validated the antigen RDTs, and we planned out as the government on how to scale this up. we're beginning in a pilot phase. Why we are beginning this is to gain confidence and competence of the users. It needs training, so we cannot massively roll it out. So it will be a pilot phase as we generate data on how this perform. So we shall begin with, and we decided as a country on who should we begin with as for use of antigen RDTs, and we listed out the kinds of patients that we should use. One are those patients with COVID-like symptoms. If a patient presents to a health facility with COVID-like symptoms, they will be subjected to an antigen RDT. If it's positive in a pilot phase, they're supposed to isolate this patient awaiting confirmation as we build confidence. But after some time, when we build confidence, a positive will be a positive. So we shall also use them in frontline health workers that are symptomatic, in contacts of cases that are symptomatic, in contacts of cases in these very big congregations, to try and break the transmission cycle. We've started that way to build data, to get more data and confidence in use of these antigen RDTs. We are not actually going to use them for points of entry or airport screenings, because we've known from the validation that they only work when the viral load is high. So the symptomatics, their viral load is low, so rarely will be exposing the false negatives that could come out of this. So that is the plan we have as Uganda, but with a lot of caution, because it needs a lot of regulation, a lot of proper monitoring, because if we let it be used where it's not supposed to be used, we can get a lot of false negatives. People can use them on the market to screen any asymptomatic, and if it's false negative, it is taken up, and then this can cause a further outbreak. So we need to have a lot of regulation, a lot of training. It comes with that. But all that said, because of the cost that is to use, we're excited that we are going to increase our testing capacity beyond what we are actually using. Currently, we've not yet adopted serology, antibody RDTs for diagnosis, because majority that have been validated to not catch the infection as early as possible. So they're not useful, really, the ones we've seen are not useful in the diagnosis. But as guided by WHO, very good in surveillance, and that is the plan we have, and for research. But we're excited that WHO let go the use of antigen RDTs, and it's going to be a very big game changer, but we need to use it with caution, with training, competence, quality check, monitoring and evaluation, so that we are able to really produce the right result that we need to produce. Thank you very much, and over to you.
Thank you very much, Dr. Nabata. Very comprehensive account of what Uganda is doing. It's now over to my colleagues for questions. Please, as I noted earlier on, use the Q&A function. There are a few of you who already indicated that you'd like to ask some live questions. So without much delay, let me hand over to Naftali Mwara, my colleague from Shinwa, Kenya. Please go ahead and ask your question. You can unmute yourself.
That's a piece of. My question goes to Dr. Moeti. Can you hear me?
Yes, we can. Go ahead.
I just want to know how overall, how would she rate the testing capacity in sub-Saharan Africa? Are we average, are we above average, or are we below average?
All right. Thank you.
Okay, yes, thank you. That's an important question. I mean, first of all, I would say that the testing capacity in Africa has greatly improved from where it started off at the beginning of the pandemic. We say this often, that, you know, as cases were starting to be seen in the African region, there were only 2 labs that were able to detect this this virus. One was in Senegal and one was in South Africa. And now we have countries all over, all the countries are able to test. We had 2 labs able to test. Now we have 750 able to test. So it's been a tremendously huge improvement in the capacity to test. I think the colleagues did state that there was a concentration initially very much around the capital cities, around the towns, but we see more and more this capacity being spread out within countries into districts as we see that the pandemic has a potential to spread all over. Also, the rate at which countries are testing has, of course, also improved. On average, countries in the region at the beginning were performing about 4 tests per 10,000. This was in about April. Now we have on average, if we take an average for a continent where there is a great deal of variation, admittedly, around 113 tests per 10,000 people. But the range goes from 8 per 10,000, and we see this in some of the lower income countries to something like 1,451. We see that the middle income, smaller population countries have a higher testing rate per capita. So as I said in my statement, compared to other regions, we still are a bit less than average in African countries. So compared to countries in Asia, which have more resources, both human as well as the infrastructure of the laboratories, and certainly compared to a worldwide average. But what we can say is that the countries have made tremendous effort with the support of partners ourselves, the Africa CDC, and as we said, this availability of this testing, this new RDT, which is seen to perform better, is going to additionally change the situation for the better on the continent.
Thank you very much, Dr. Moeti. And I've got a question here from Mary Fick from Reuters. It's posed to both Dr. Nabada and Professor Ture. So if I could ask Professor Ture to answer first, and then Dr. Nabada, you'll answer next. But the question basically is about capabilities and whether or not you've been able to get the testing kits that you've needed, and most importantly, whether wealthier countries have been favored, especially in terms of supplying the kits over the poorer countries. Professor Ture, what is your experience in Guinea-Conakry on these 2 issues raised by Maggie Fick?
Bon, je ne sais pas si c'est la traduction. La question, c'est si nous avons les kits dont nous avons besoin. Je dirais que oui. Nous n'avons pas, depuis le début de l'épidémie, la Guinée n'a pas été en rupture de tests de diagnostic, que ce soit la PCR ou que depuis que nous avons commencé à utiliser les tests de diagnostic rapides. Au tout début de l'épidémie, nous n'avions qu'un seul laboratoire, le laboratoire qui surveillait les virus respiratoires en Guinée, qui avait commencé le test après une évaluation avec l'Institut Pasteur de former également les laboratoires des hôpitaux régionaux qui ont de la biologie moléculaire à faire le test. Et donc, je peux vous assurer qu'à ce jour-là, nous n'avons pas de rupture et nous n'en avons jamais enregistré. Donc, avec l'appui de tous les partenaires, Dr. Moeti le disait tout à l'heure, l'OMS, Africa CDC, l'OAS, et puis également les efforts au niveau national, donc l'État, il y a toujours eu des kits dont nous avons besoin. Maintenant, la question, c'est tous les jours, nous devons aller de l'avant, nous devons chercher à avoir des kits qui peuvent encore nous simplifier le travail, aussi bien en biologie moléculaire qu'en PCR. En PCR, par exemple, on peut toujours avoir des kits peut-être qui peuvent nous permettre de gagner en temps, et ça doit être une course, on va dire, un peu perpétuelle. Mais nous n'avons pas eu de rupture et nos laboratoires fonctionnent sur la base de ce qui vient de l'étranger et de ce qui est acheté par notre pays. Merci.
Thank you very much. For Uganda, as when we started, we all know that there was a lot of global competition, very few reagents for COVID testing, and with a lot of competition and the lockdowns, it was very hard to have access to these reagents. So in Uganda, at the beginning, we had a lot of support from the donors, WHO, Global Fund, CDC, Africa CDC, through a consortium. But this consortium would ration depending on the cases that you have. So you would not get all the reagents you need to be able to test. So we had to prioritize on who to test. But as we've seen that as now time goes on, more are coming on the market, more products are coming on market. We hope this will lessen. But at the beginning, it was very tight, so you could run out of reagents from one lab and you switch to another lab, and all the reagents that would come in would get them rationed, very limited, so we couldn't really test as we wanted. Sometimes even if you had some money to buy, it was very hard because of the competition and the kinds of the equipment that we had, the kind of reagents like Roche or Abbott and GeneXpert were very hard to get. As we speak, I think we've only received one GeneXpert supply for only 10,000 cartridges. Very hard to get GeneXpert cartridges because of the global need and the first world that needs all these cartridges. So, but we think as now we move on, more reagents are coming on board, open platform reagents that we need to validate so that we have less competition for these reagents that cannot be let go, like the GeneXpert, the Roche, the Abbott, that had to get. So that's how we've been in Uganda, with a lot of support from donors and government also buying, but the competition and the global competition for the reagents has been the biggest challenge to have reagents in the country. Over.
Thank you, Dr. Nabada. Before we move on to other questions, Dr. Mweti, I believe you'd also like to weigh in on this, something that you've mentioned before, equity of resources, a very important issue for the WHO.
Yes, I would like to just say, from where we're sitting in WHO supporting 47 member states to have access to these supplies for testing, actually, I would say it probably was one of the most difficult aspects of the response. I think our colleague from Uganda has said pretty well. We saw that not only was there, of course, a global competition, so the market was very distorted, but we saw a couple of things. One, those countries or entities that had the resources were able to pre-book and get and sort of dominate access to the supplies. And also some of the countries where the manufacturers were, in some cases, prohibited the export of some of these items. So we had a very distorted situation at the global level in terms of the market. I'm mentioning this because, we're looking forward now to what have we learned from this pandemic, what needs to be put in place for the future. And we've understood that there is a need to think through, as part of the preparedness, some sort of global supplies, logistics platform where some principles are agreed among the private sector, the countries, and the multilateral agencies and the funders on how to promote an equitable way of ensuring that as countries need these supplies, it is much easier for countries. Believe me, some of the most agonizing moments that my representatives had at country level was around the challenge of being able to provide some of these supplies to member states. And we think that there could be a simpler way, looking ahead, planning for the next pandemic, working together around these principles of, equity, solidarity, while we continue to create the market to make sure that countries don't have to go through some of these very difficult decisions. I just wanted to highlight that because now we're starting to look forward, and it's something that we need to work on collectively.
Thank you very much, Dr. Mwedi. We do have some more live questions that are coming through. And just to mention to colleagues, I know quite a few of you have several questions in mind. If you can truncate them, keep them as short as possible. So if Rhoda Odiambo from BBC Africa is live, Rhoda, you can go ahead and ask your question.
Thank you, Sepi. So I have two questions for Dr. Mweti. Sorry. You talked about the RDT test, and Dr. Nabada gave a criteria of where and who they're going to be using the RTD test for. And my question is a concern for travelers, because many countries would be asking for the COVID-19 free certificates, and they would be looking at the results from PCR tests that had been done. So is the WHO also, is there a criteria now that the RTD test will be available in countries that travelers perhaps would now be able to get COVID-19 free certificates and their results from the RTDs? And my second question is, of course, that on COVID-19, has the WHO seen any cases of people who've been infected twice with COVID-19 in Africa, seeing that there are about 5 cases globally now? Thank you.
Dr. Mweti?
Okay, thank you very much. I thought that the summary that Dr. Nabada gave of the decisions on how to use this test or these tests in Uganda pretty much reflects the WHO position. So at the moment, WHO is not recommending these rapid tests for use at the cross-border in the cross-border or point of entry in terms of giving somebody a certificate of being free of COVID-19. We are going to continue to look at the performance of the tests, the particular context in which they're going to be used. So I think it's pretty much around where there are people with symptoms, where we would like where countries would need to do surveys to detect if the virus is circulating in certain areas, to follow up on the contacts of cases quickly and in relation of healthcare workers. So these kinds of circumstances, and particularly to be able to use them in areas where you do not have either the infrastructure and where you can train the staff quickly to be able to use such a test and to make such a huge difference in terms of the turnaround in getting the result, and therefore the follow-up actions in finding contacts, for example, isolating the people who are confirmed to be carrying the COVID-19. So the answer is not yet, but WHO is continuing to study these tests, and we will be looking to work with countries as well in terms of the validation of their performance, because one of the big challenges that our countries face indeed is the testing at points of entry and the accumulation of numbers of truckers or travelers, where such a rapid test would make such a huge difference. And these are some of the places that make the biggest demands on the capacity, the supplies of our countries to test, sometimes disadvantaging testing in the more clinical and other surveillance within countries. So it would indeed additionally be a game changer. And then you asked the second question about whether there have been cases of people getting infected, getting reinfected. So far, we don't have any information on the continent of that. And then those of our colleagues who are looking at the genomic data, no cases have been reported showing reinfection. But I think this is a matter, again, on which we need to, with the rest of the world, to study and understand progressively more and more what are the possibilities and the risks of this, which will determine what a refinement of the strategies then, and even more cautions to be taken. Thank you.
Thank you, Dr. Mweti. There's a question here from Andalou Getsuchu from the agency in Addis Ababa. So the question is pretty much along the same train of thought about the testing capacity, but in this case about the ability to isolate, saying that countries like Ethiopia, they've experienced a lack of space. How should they deal with this? Because there's not enough space to isolate the virus and minimize the spread. And there's a lack of space to quarantine. So what would you advise, Dr. Mweti? And I know Professor Ture also spoke about this earlier, so perhaps we can also get him to weigh in. Dr. Mweti, let's start with you.
Okay, thank you very much for this question. So maybe just to involve my colleagues who are online, I will ask Dr. Nsenga Ngoy, he's online, isn't he, to respond to this question. Ngoy.
Thank you very much, Dr. Mweti. Thank you to colleague who asked the question. I think first to clarify whether it's quarantine or isolation, the difference being isolation for person who has been tested positive, and then to put him or her aside, to prevent other infection. Of quarantine of person who you are suspecting that he might be, he caught the disease maybe, but he is not yet tested, so you are putting them aside, like people coming from abroad. So now, if it's about quarantine, that's why WHO is recommending, first of all, the most important measure is to test. Test and test and test as much as you can. Now, if we are testing and you have so many who test positive, you need to isolate them, then in that case, in some circumstances, WHO has a guide on how you can isolate people with no symptom who might be post-symptomatic, who in a very safe manner at home. But again, that has to be really, really after risk assessment, because in our context, especially in our African context, sometimes it can be very challenging in some area to isolate at home because of our proximity and the number of people we are having. But that's feasible. Now, in terms of those coming from outside, again, that's why we are recommending as WHO is first to have people who are testing. Then if the test is negative, there is no point or reason to isolate or to put them in quarantine unless we have the reason to think they might be infected. Over.
Thank you very much, Dr. Ngoy. Professor Ture, you mentioned this earlier on, the issue of space, and what my colleague Getutu here is saying from Addis Ababa is that even intensive care units are filling up. So in your experience, what have you done in Guinea-Conakry? Perhaps if you could share that.
Merci. Donc, pour ce qui est de la Guinée, peut-être nous avons eu un petit avantage, c'est l'héritage d'Ebola. Après l'épidémie de la maladie à virus Ebola, dans tous les districts sanitaires, nous avons construit des CTP, des centres de traitement épidémiologique, qui sont à côté des hôpitaux préfectoraux, donc ils peuvent recevoir les malades. Donc, pour l'instant, la question, en tout cas pour ce qui est de la Guinée, il y a moins d'inquiétude pour l'isolement des malades pour ce qui est de l'intérieur du pays. Et pour ce qui est de la ville de Conakry, nous avons réquisitionné le grand hôpital national qui était en finalisation de réhabilitation. Là aussi, c'était l'héritage d'Ebola. Après l'épidémie d'Ebola, le grand hôpital national, le gouvernement a décidé de faire son extension et la fin des travaux. Donc, il a été entièrement réquisitionné pour hospitaliser les malades. Mais c'est vrai que ces deux n'ont pas totalement permis d'héberger tous les malades. Donc, en plus de cela, deux structures privées ont été réquisitionnées pour héberger les malades. Dans tous les cas, je voulais dire que pour l'intérieur du pays, nous avons un minimum d'infrastructures qui a été mis à disposition. C'était les CTP, c'est ça surtout l'expérience.
Thank you, Professor Ture. The next question is from Paul Adepoju, who wants to know about, and Dr. Moetu, this is posed to you, about the specific tests that the WHO is giving out to African countries and how many are able to roll this out, and are they ready to roll out these tests, and will there be a need for some sort of adaptation locally for individual African countries when they receive these tests? And I'm sure Professor Nabada can also weigh in on it afterwards, but let's start with you, Professor Moetu. Dr. Moetu. I was called Dr. Tsepiso earlier on, so I think I might as well confer Professor Moetu to you.
Okay, thanks very much. So Tsepiso, if colleagues don't mind, I'll bring in my colleague, Dr. Omar Coulibaly, who is one of our lab experts, to speak specifically around this test for which WHO has issued an emergency use listing and provide some details about it. Dr. Coulibaly, come in.
Thank you, Dr. Moetu. Good morning, everyone. Those antigen tests are new tests in our countries and even in the world. So all the countries are called to make sure about all the process for importing and including new tests in their testing strategy. What we are advising countries to do is first on the regulatory side is to make sure that those tests are authorized to be imported in the countries and also that they are considered for post-market surveillance to make sure of their safety and of their efficacy, and also to make sure that those tests are the ones the countries need in terms of, that usually some false tests come into the countries This can be easily detected when in the regulatory side, the countries are ready to import the test. The second thing to do is to make sure about the performance of the test, to make sure that the test is efficient in terms of detecting real case of COVID, and also have a good specificity by when the test declares, for instance, somebody negative, to make sure that that person is really negative. And then the country should also revise its testing strategy to see how to include the new test within the strategy already in place, how to use it compared to, for instance, molecular testings, and where to use them. Use them into the big cities where there are already laboratories, or into the in the remote places, in kind of specific population gathering, for instance, in refugees camps and things like that. So the testing strategies should be revised and accommodate the new testing strategy. And I said it at the beginning, the post-market surveillance, the country should have an eye on the test to make sure that it really responds to the need, and it's also safe and efficacious. I'll stop here. Thank you very much.
Thank you, Dr. Coulibaly. Dr. Nabada, you shared the process, the plan that you underwent when you were embarking on the rapid diagnosis tests. If you also want to weigh in on these questions, just if there were any local adaptations that you had to make, and what were the considerations?
Thank you very much. True, we had to have local adaptations. First of all, WHO guides that when you're getting a test, you're supposed to have a local performance evaluation to see if it actually works. But we only evaluate those that have got emergency authorization that are on the WHO list to be able to get evaluated. So we did that for some, and those that passed are the ones that we planned to roll out. And as I've said, we specifically came up with a strategy of rollout in a phased approach, because we needed to train, we needed to generate more data, we needed to build confidence and competence in the users, and we decided in a phased approach on where to begin from. As he has said, we actually, all the positives will be subjected to a PCR test to really confirm that as we build confidence in this. So that's also another adaptation that we have. Until when we have this confidence, then we shall change our testing strategy, whether when you have a direct RDT positive, you take it up immediately. But we are approaching it in a phased manner, in a pilot mode, in particular populations, but with a lot of caution and a lot of regulations. As I said, one is it must be an authorized RDT. Two, it must undergo evaluation. We must do a post-market surveillance. We must look at the safety, where it's going to be used. So that we are sure that what we are actually doing is right for the RDT. So that's the planned approach. We are just beginning, and we'll have data after some 2-3 months on how this is working. Over to you.
Right. Dr. Mwiti, would you like to add to this?
Yes. Thanks very much, Sepisa, and thank you, colleagues. No, I just wanted specifically to say, for some months now, WHO has been working with a consortium of partners, including a group called FIND, to test some of the most promising of these rapid tests. And in September, on the 22nd of September, we're able to issue the first emergency use listing for an antigen test. So basically that's based on data and the assessment by a number of researchers around the world to ensure that it fits the recommended standards for quality, for performance, and for efficacy. So in a way, that's some of the excitement that we have arrived at this point. We are continuing as WHO with our partners to assess some of the other most promising tests so that they can be then, if you like anyway, validated by WHO, because there's a huge range of tests that are available on the market. Some of the precautions and steps that my colleagues have talked about are still necessary, but we've collected data from a range of places where the research has been carried out on these tests, and these are being recommended by WHO, and we hope progressively to do that with more of these tests. And it is these that are about to be, if you like, procured and provided, hopefully in quantities that make a huge difference as to their availability to change the situation in our countries, to be able to get better on top of the entire intervention. So the surveillance, tracing contacts, doing surveys where necessary to detect whether the virus is circulating. Thanks. I just wanted to bring that additional precision.
It's fine, Dr. Moeti. While I still have you on the floor, there's a question here from Esther Nakazi, who's a freelance science and technology reporter. And basically, the question is around the clinical trials of urban medicine for COVID-19. And the question is, who's sponsoring these trials and how are they progressing?
Okay, thank you very much. As you know, the clinical trials, there's as part of the ACT Accelerator, we were, WHO was coordinating, working with other partners, a series of trials of diagnostics, of therapeutics, which have been funded. We have a clinical trials called the Solidarity Trials, where several products were being tested. And this was based on financing coming from international partners. So from some of the donor countries who are providing support for the response, WHO was able to pull together and to put in place trials in a number of countries. Specifically in relation to traditional medicine, there was an initiative from the government of Madagascar that we've all heard about on a certain product that they were trying, which has been joined by a number of African countries as well. We worked with the government and with the Africa CDC to put in place a technical group to support technically the design of the study, the review, the regulatory part of things, to make sure that the trial was being carried out in different phases, as we have advised in our work on traditional medicine as WHO over many years. And so that we would go through the first and second and then third final phases of the clinical trials. So this is being financed initially by the Madagascar government, and we are expecting that other partners might come on board. We know that phases 1 and 2 of clinical trials are taking place in a number of countries, of course in Madagascar, but also in Burkina Faso, Ethiopia, Guinea, we understand Mali, Nigeria, South Africa too, and Uganda. And then we expect these to progress to the final phase of the third phase of the clinical trials, where then it will be clear how this product is going to be used. I'm not really sure of the details of who is funding. I imagine it's some of the governments that are participating with support from some of their partners. But we have been very much involved at the level of providing the technical advice, linking up to our pre-existing partnerships around clinical trials, regulatory framework in Africa, and some of the work that we've supported in the past on traditional medicine. Thank you.
Thank you very much, Dr. Moeti. This question is from a colleague from the German press agency, Goya Foster. And the question really is, why were these rapid diagnostic tests not used before? Was the technology not available at the start of the pandemic, and how many African countries are already using these rapid tests already, and where are they produced? If I could just ask Dr. Nabata to answer this question, and we'll come to you, Dr. Moeti. And I know Professor Toure as well did mention that from earlier as May, they were looking to use these rapid diagnostic tests. So we can also get you to weigh in on that. And I think it goes pretty much along the lines of what Sarah Yerving from DevEx is asking about, what the restraints that prevented the rollout of this earlier on in the pandemic. So I think the questions really are similar. Dr. Nabata?
And thank you very much. Right from the beginning, the recommended test for diagnosis by WHO was a PCR, as they were waiting to see the performance of the rapid diagnostic tests. At the beginning, we had a lot of rapid diagnostic tests that were antibody-based. A number of them were produced, but by WHO guidance, these were not yet allowed to be used for diagnosis. Actually, up to now, they're not yet allowed to be used for diagnosis. They are recommended for surveillance and research, but the antigen tests came on board. But all these tests must go through stringent validations and evaluations to really see if they produce what they are supposed to produce, to have the specificity and the sensitivity that is needed to make a proper diagnosis. So a lot has been going on, and I think that's why WHO has been having all this waiting for the evaluations from the different organizations and agencies, until when there was a breakthrough and we had information on the 11th, on the 22nd, when they put up on their list, they pre-qualified some antigen and RDTs to be used. But I think it's because they needed to go through the stringent measures to be able to produce the right quality test with a good sensitivity and specificity. That's why we took time to adopt, and we're glad that finally, when this was announced, a number had been validated, performance evaluated in the country, and we're ready to start rolling them out. But my colleagues from WHO can give more guidance, because we are guided a lot by WHO in what we do. Over to you.
Dr. Moeti, if you would like to answer, I'm not sure if you want to hand it over to Dr. Coulibaly as well to respond to this. So it's about basically what the guidelines were. I think you spoke about that earlier on. And if you could also talk about who's producing these tests. Are all countries already using them, especially on the continent, African continent?
Okay. I actually think that Tanamada put it very well, that you know, in the situation of a pandemic, which is affecting all countries, of course, there was a tremendous effort by different companies to develop the technology to produce some tests. As I said in my previous remarks, there was a huge challenge to have access to such tests. And there were tests, many tests of a whole range of performances, as far as, if you like, false positive, meaning you do the test and the person is negative, but it actually shows as positive, and then false negatives, which means you do a test, the person is infected, but it doesn't show in the test. And therefore, this would have very big implications as to the subsequent actions then, in terms of tracing contacts, controlling the spread of the virus, making sure we monitor people in case they start to have symptoms, and so on. So it's been then the challenge of navigating, and frankly, there were very many tests that were produced whose performance was not good enough for WHO to pre-qualify and recommend them for use by member states, because we need, when we develop guidance, to set certain standards as to the performance, effectiveness of all the products that WHO reviews. And that has been the big challenge in terms of this huge range of tests available, which could not be recommended by WHO, and the work that's been done then to work with researchers in many countries to have a big enough sample size of tests that were seen to be the most promising. So the test whose emergency use listing was released by WHO on the 22nd of September is produced by a company called SD Biosensor, and is what has been recommended so far by WHO. We know that there are other tests that are also being analyzed in a similar way. And I'll turn it now to Dr. Coulibaly and hope that he has the information more specifically. But I think it's just to say there is a whole range of tests on the market. Companies are working on developing this, making them available. The responsibility of WHO in making a recommendation to countries is to make sure that they respond to certain quality standards. And therefore, we can recommend them to member states to use. Otherwise, we recognize that there are many available. We also provide guidance which highlights the limitations of using certain types of tests so that countries know if you find you are compelled to use something, know the limits of how it will help you and understand the cautions that you have to take in interpreting the results and in a sense, use your judgment in that case.
Thank you, Dr. Moeti. Dr. Kulbali?
Thank you, Madam. I think that Dr. Moeti summarized this so well that adding anything can just be, kind of awkward. Thank you. Over to you.
So let's get the final comments now from the panelists. And perhaps if I could start with you, Professor Toure. This last question from Sarah Chodosh from the Popular Science publication in the United States. And it's a question that's often been asked, but I suppose in this case it relates to testing, speaking about how we've seen low rates of COVID-19 in Africa. Do you think testing now will see an increase in the numbers? And if not, what then can explain why Africa has come out of this better? If testing increases and the numbers don't come out, is there anything else that can explain why Africa is ahead of most of the world? So this is a question. If you could just say something with regards to that in your closing arguments or presentation, Professor Toure.
Allô, je suis désolé, la connexion était perdue. Bon, je suis venu, la question était en train d'être posée. Est-ce que quelqu'un peut revenir dessus? Parce que j'avais perdu la connexion.
So the question is basically around testing. Now that these rapid diagnostic tests, do you think that we will see an increase in the number of COVID-19 cases in Africa? And, what is the relationship? Or is there something that is beyond us that we're not seeing why Africa is ahead of the rest of the world in terms of the low numbers? So that question is from Sarah Chodash from Popular Science in the United States.
D'accord. Merci pour cette question. Mais je pense que si nous partons de l'expérience de la Guinée, parce que nous avons commencé à utiliser les tests de diagnostic rapide un peu plus tôt. Donc, si nous partons de l'expérience de la Guinée, on ne pourra pas dire que
Professor Toure, unfortunately, we seem to be having a bad connection to you. I apologize to you and of course our panel.
Les autres, peut-être nous allons avoir plus de possibilités de diagnostiquer davantage de cas.
Professor Toure, I'm going to ask the sound is distorting rather badly. We'll move on to Nabada to get your final remarks. I do Professor Toure. So,
pourrait rester probablement les mêmes de la dynamique de l'épidémie, de son évolution de façon générale. Mais la mise à disposition.
Okay, so I will ask Frederick, please mute.
I don't know what that means. If you like, I can search the web for. Okay, so I will up.
Professor Toure, unfortunately the connection is bad. Francois, if we could please mute that. Dr. Nabada, if I could ask you to please respond to that question in your closing. You were overtaken by Siri there, who's answering a question that was not asked to her. So I'm hoping we could have a health-related response.
Thank you very much. I wanted to get to know the question he was answering.
So the question really is about these rapid diagnostic tests. Do you see them improving or not in terms of the numbers? The question is around the fact that there have been such low numbers in Africa. Are we going to see a difference now that there are these rapid diagnostic tests? And if not, is there something that we're not seeing that Africa is doing to be ahead of the curve, so to speak, compared to the other countries, especially in the Northern Hemisphere?
Oh, thank you. The low numbers could be explained by a number of things. We might not be testing as we expected to test, and true, we are not testing as we expected to test because of the reagents that we are having. We've all been using PCR reagents, which are hard to get. That's why most countries are doing targeted testing. So maybe that could be one of the reasons to have low numbers. But also when we get on board, especially the antigen tests, you've also seen they have limitations. Who should they test? They are going in for mainly symptomatic cases. So they will be identifying also a particular population of groups. So maybe that can also keep us on low numbers. But if we get in more kits with better performance that can go beyond and detect low viremia, where we can end up starting doing massive testing, then we shall start seeing the numbers rising. But I think because of the capacity that we have, the reagents that we have, it might hinder our true picture of the number of cases that we have, because we are not testing everybody. But as you said, that as we move on, more RDTs will come on board. They will be given more time. Now it's no longer really a lot of emergency, so they might be given a lot of time to get authorized, such that we have good quality, more quality tests in terms of RDTs, both antigen and antibody, which will increase access to testing, and we might see more numbers coming on board. I heard from Guinea that when they started use of the RDTs, their testing numbers went up, and the identification of cases also went up. So I think that is it could be one of the causes that we are seeing, that we are not seeing a number of cases in Africa as compared to the developed countries. But that said, I think I can also give my remarks now, my final remarks. Yes, first of all, I want to thank WHO, and I want to thank all of you for giving us this opportunity to share our experiences in COVID in Africa, but as Uganda. It's been a very challenging pandemic in terms of the lab, because it came in when we were not really ready for it, yet we really needed to make a diagnosis. But we are great. We are happy that we had some infrastructure that we backed on to be able to start testing. So when we start seeing new technologies coming on board to be able to increase access, we are very glad, because this will change the whole scope of the testing strategy, the whole scope of increasing access, hence diagnosing more cases, isolating or quarantining people, and hence breaking the transmission. And if we break the transmission, then we'll be controlling the pandemic. I thank you very much. It's been a good time to share and hear experiences from other countries, and from the WHO for the guidance that we've given, and we shall keep waiting for any new updates to be able to change, because we've seen a number of changes of updates and interim guidances coming in. That means it's not a static pandemic, it's dynamic, so things can keep changing, and we need to move with the change. Thank you very much to the organizers. Over to you.
Thank you very much, Dr. Abada. And just on that note, Dr. Moeti, there are some questions here, one from AP and one from Maggie Fick from Reuters again, and she wants to know if there's been any interruption of HIV treatment in sub-Saharan Africa as a result of COVID-19. seeing that there's been no vaccine to treat this. And the question from Jamie from AP is basically around the accuracy of these rapid diagnostic tests. Do you have data on that, the negativity, positivity rates? And is it as much of a game changer as Dr. Nabada was saying? Is this what you're seeing? And the other question is also around the impact of the protests in Nigeria. Do you think that there could be a further outbreak as a result of what we're seeing there? So in closing, Dr. Muideen, I'm not sure if you would like your experts to also weigh in on those questions.
Okay, thank you very much. Has there been interruption of HIV, access to HIV treatment by people? I think we've seen, the physical distancing lockdowns, I'll call them just to be quick, that had to be imposed. And the fact that there was concerns about gathering, including people coming to wait in the waiting rooms of health facilities. There certainly was a slowing down of access to many services, both antiretroviral therapy, immunization for children, access to family planning services for women, chronic disease care for people with hypertension, diabetes. Definitely the pandemic, especially at the time of the slowing down of people moving around, did have an impact on people being able to get their regular services. As WHO, we've developed a strategy and initiative on access to essential services at the same time as the response to the pandemic is going on. And we're working with our partners, some of the major funders like the Global Fund, Gavi, and the global financing organizations for some of these specific health problems have supported countries to be able to then make adaptations and to be able to continue access to services. So it means you have to adapt. Instead of people gathering and queuing, you need to provide services in a way that you can respect the physical distancing. So the scheduling of such sessions, more outreach type service delivery is being organized so that we catch up. And we don't then have problems of people having complications or even dying of other problems because of the fear and the precautions that have to be taken because of the COVID-19. And then secondly, I think we've already talked about the accuracy of the tests. So a large number of rapid tests have been available on the market. Some detect antigens, meaning are you infected? Some detect antibodies. Have you generated antibodies as a result of being exposed to the virus? And there have been a great range of the performance of these tests. Many of them have had really serious challenges in terms of how sensitive they are, and the range has been from, 20 to 30% right up to the 80s. So there's a lot of work. So the central theme that we've discussed today, the fact that there's been a couple of tests that are starting to be seen to have a performance that's documented to be adequate, is what we're talking about. And these will indeed make a big difference because I think it was said very much by my fellow panelists, they are simpler to use, easier to use. What you need is logistics, and even the level of skill and training makes it easier. So they can be spread out. They can be used and not in the national lab where you have the sophisticated capacity. Because the point that we need to emphasize now is that the lockdowns are being eased. So we are at a point where people are going to have to move around more. The economies have had a big knock because people couldn't move, businesses closed, etc. This is being eased. And therefore, the public health capacities, including the ability to quickly identify people who have had exposure to or are infected with the virus, are more urgently than ever needed to be spread around in countries, expanded, so that when somebody travels from a capital city to somewhere in the hinterland and they happen to be infected, it can be possible to identify them quickly and take the public health steps that will stop spread again and an uptick of the number of cases. So for us, the meeting together of this capacity to expand even geographically, a simpler test to use with all the precautions, and the fact that the challenge is increasing as the lockdowns are being eased in countries is a very good coincidence. So I'll just end with the remark that two things. One, those public health capacities, we need still to continue to build them up, including for isolation of cases as might be needed. And then finally, the people ourselves, each one of us, need to know and be enabled to do our part so that we contribute taking the right precautions and we prevent the uptick of cases where we have seen that our region, our continent has been affected much less than we thought, came at a huge cost. And let's keep going and use all the technology that's emerging to be able to prevent a huge resurge of cases. I'll stop there. Thank you.
Thank you very much, Dr. Moeti. I think a great positive note to end it on. Thank you very much to Dr. Matshidiso Moeti, the WHO Regional Director for Africa, joined by Dr. Nsenga Goy and Dr. Sheikh Omar Koulibaly, experts at the WHO. And we also want to thank Dr. Susan Ndide Nabada, from the head of National Health Laboratory Services, the Central Public Health Laboratory in Kampala, Uganda. And thanks again to Professor Abdullahi Toure, the Director General of the National Institute of Public Health in Conakry, Guinea. We do apologize for the technical challenges, but there is, as you know, when technology is involved, there's no accounting for that. So thank you very much to all of you, our colleagues, for joining us. I hope you were able to ask all the questions that you can, and we continue to endeavor to make sure that you all get an opportunity. That's the end of the briefing. Thank you so much for joining us.
Thank you. Thank you very much.
Thank you.